burr which creates a margin which is equal to the enamel what I want to expose. Then I have my finishing burr. This is not the red Mani finishing burr, but this is a red burr tooth prep finishing burr. You need to have this, and then for the proximals, you need to have a thin tapering burr, which is very essential. Okay. These four burrs are mandatory, and for occlusal reduction, I have this burr from Strauss, I think, so that you maintain the cuspal inclines. So these are the burrs what I'm going to use. So somebody has to be here to do the chip blowing stuff. So this is the handpiece what I'm using. You see the blue ring? The blue ring is an electric handpiece which is 1:1. That means I use it for my finishing and polishing for my composites. If it's 10, it's just 10,000. Whereas in the red ring, what we use it for tooth preparation in the patient is 1:5. If it's 10, it's 1 lakh. So we need these two handpieces when you're using electric motors. Unfortunately, the handpieces are 25k each. So this is an electric handpiece. You see how smoothly it starts to cut. So the first thing what I'll do is generally I want to finish off my occlusal stuff. Then I know easily where to put my margin. So this is a classical prep. No tooth wear, nothing. I assume how to do an ideal prep. Then we move on to situations. Okay. The first thing what I'll do is put the depth reduction burr. Yeah, this is better. Central groove. Then do it on the inclines and exit out. You have to use this. That's why I know somebody asked me, do I do the build up to full contour? Now you know why I do the build up to full contour. Otherwise you'll have no clue how much is your occlusal reduction. You cannot blindly grind the tooth. You cannot eyeball and tell, like yesterday we did it, that oh my god it's 1 mm, oh my god it's 2 mm. No. The depth reduction burr should exit the cusp. Okay. So let me check it out. Yeah, it should exit the tooth. Can you see this? It's exiting the tooth. So once I do this, the next step I will clear up this. You don't have to do any pencil markings like how I do it in the laminate. And then so this burr is nice and cool. It's already angulated like the cuspal inclines. You don't have to do the 4 cuts, just cuspal inclines maintain, that's all. As a laboratory technician, for me that's enough. Don't make it flat. Yes, can you see that? So some people do stop. After the concept of bonding, there is nothing called as functional cuspal bevel and non-functional cuspal bevel. So you saw this what I'm doing, and then this burr will take care of the central portion also. Okay, till the burr marks go away, please try to, all the mistake happens only in the groove area. So please make sure that okay. Now my occlusal reduction is done. Now I know what is my crown height. I would love to place my margin at the equator, so I would love to do it here. Okay, so if it is here, If there is no sufficient height, then I dip it down. That's why I always finish this occlusal margin, occlusal reduction, then I move forward with my labial and lingual reductions. Okay, now I know where my equator is. Then please follow the contour, don't make it flat, just follow this contour. This bevel is a nice hollow ground bevel. So don't try to break the contact in the interproximal side. I want the entire burr tip to be in the margin. Only then it's easy for us to design and fabricate a restoration. And also there you see, and then I go to my lingual side. Okay, yeah. Once you do this, you saw the margin. So once you're done with this, don't give taper. Look at this. This is where we are now. Don't give too much of taper. Then what you do is that take a thin tapering burr and slice it through the interproximal. So don't use the same. I want the same thickness in the interproximal, but I cannot use the burr. That will hamper the adjacent tooth, create burr marks. So generally what I do is that I use a thinner burr, trying to, even if there's a composite, I try to leave a small wing. Thin tapering, this is Mani burr. Bring it at the same level. So you will have a thin wing of tooth on the composite there. Let it be there. Okay, that's how your margin. You just fixed where you need to be there. What is the first step? Creating space. That's exactly what I did. Now, inspect. You have path of insertion. So what I'll do is that I don't know how many of you still use this. This from Q3D as my enamel hatchet to take off all this interproximal excess. Okay. I don't allow my burr to do this. Even with composite it works, and this is what I do. So what I've done, I created space. That's all. Now I take a quick scan and see if the ribs are tapered and create a path of insertion. Otherwise I'll create a path of insertion and then start defining my margin. So the next step is creating a path of insertion. That means your prep is nice tapered and not having an undercut. The lab will not tell you anything. They will just proceed, but there will be a huge cement space. Okay, huge cement space, again a red flag for us. So I'll run it, and this burr is a tapered burr, so it will take care of everything. And please rounded off the cusp. A bevel is not required. Rounded off the cusp because I don't want any sharp internal line angles. Okay. Yeah. Once you're done with this, so that's a prep. Once you're done with this, if it's anterior, if it's a different protocol for me. For posteriors, I don't bother much than the red one. So the red burr is, again, if you want, it's from Identa. That's available in India actually. So I run this burr. Without running this burr, please do not take a scan or an impression. You see not much of powders coming off, it just smoothens it out. I just love this burr actually. So now, posteriors mostly I evaluate myself, and that's a prep. Got it? I make sure that no undercuts with my scan and then send it to the laboratory. Otherwise, ask the lab if my scan, if my preps are okay, and then finalize. This is routine. Now let's move on to something which is in premolar, upper premolar. Now what do I do? So upper premolar, what is the difference? It's now termed as Wanley. So let's see how do I do it. The same rule will apply. Okay. What rule applies is first creating space. So let me work on this premolar. Settle groove. Exit out always. Okay. Finish your occlusal reduction. Guys, this is no literature, no textbook. This is mine. Okay, my technique. That's why when we do hands-on, we teach clinical tips and tricks that's personal to somebody. You don't expect literature for all this. We modify according to your convenience and try to teach people. If you do this, if you develop your own technique, you can do it. You don't have to follow anybody. Only thing, you need the right tools. So now, I first decide my palatal aspect, because supragingival is what is very important for me. I will decide where I want to place, always at the equator. But now, it should be at the crest. Remember what I told you on the anatomy of the tooth and the gingival complex. The proximal is going to be slightly higher than the lateral and the palatal side of the bone. The bone is important. If you do anything to the bone, it will not like you at all. I'm still creating space, that's all. I've not done anything. Now is the challenge. Joining both. One is in one height, other is in the other height. You preferred position because we are doing this only in uppers. We are not doing this in lowers. You decide with magnification, what elimination, direct vision, indirect vision, it's up to you. But I strongly suggest all of you to work on typho before you touch your patient. Please. putting everything together is going to be difficult. Guys, please don't feel bad. Today we work on typho models. I sit down and work on typho models before I put my hands into the patient's mouth. All this will never get outdated. However digitally you are strong, all this needs to happen. So I sometimes check if I can do that and then put that into my patients, because patients, there are so many things that will happen. Patient will move so many things. Doing this in premolar is okay, but doing this in molar, I know it takes a hell a lot of time for me. Sometimes you feel doing a crown is better. That's why doing a crown is cheaper. Doing this is not at all cheap. So now I need to connect both. So be careful in angulating your burr. Okay, always try to angulate and then you can join them. Have the limit on the palatal side. Anytime you can take it down, but when it goes down you cannot take it up. Remember that. So I don't want the palatal to be messed up. So labially I need to come down. I know that, but I will first want to get the palatal stable. Visibility wise, molar is a problem. Structurally, premolar is a problem. Because if you overdo, you will over reduce. So all three teeth have a unique challenge. Yes. So first stabilize the palatal. Make sure you are there. Obviously here contact will be broken. Now what I do, I will concentrate and I will join, slowly create a slope like a flyover. Yeah. That's all. So my burr is slanting like this. Now can you see the slant what I'm using? So I know this is fixed here, but I just want to take this off. That's all. This slant is going to be very, very important. I'm doing this only to reduce the aesthetic risk. So I see that aesthetically it's all good, and then yeah. Okay. Oh wait. Yeah, when you see this, you will see the margin coming and going up like a flyover. Now I will again run my burr, the green burr. Carefully run it. Joining everything now and making sure that you rounded off your preps. Guys, premolars are tricky structurally because you can easily overdo. You see the stability of this burr now? This is a beauty with electric handpieces actually. Yeah. Once I'm done with that, then I use my red burr to finish it up. So no occlusal bevel, just rounding. Why rounding? I don't want my machine to get stressed up, otherwise my machine doesn't like all this. And then no sharp line angles, and this is what you do. You have your prep starting at one position and ending in another position. So this is what is your prep. Yes. So this is also tabletop, but only thing to reduce the aesthetic risk, I've done this. Okay. So now comes the actual clinical scenario. So I'm going to put these models here. So now, when a patient comes with tooth wear, what do I do? Oh, I need tissue paper. I'll leave it here. Tissue. Or we'll just wipe this area. No, I have black glove. It's okay. I don't have my staff left. They got it. Wait. Okay, I'll need a glove. No, it's okay. It's okay. I bought a black glove. I'll use the regular glove. I thought my staff left. Now let's go to clinical scenarios and regular gloves. First thing is tooth wearing. Okay? So here is what? This is much clearer. Okay. Do you see this? I created a defect here. No anatomy. Can you see that? Tooth, where? Where will you put your depth reduction? Where will you put your depth reduction? I want a clearance from the final restorative work. You need to get mock-up done. This is P2. P2 is mock-up. P1 is you gave data to the laboratory what? Centric. They developed the ideal tooth position and you should have a printed model. Can somebody mix a little bit of putty for me? Putty. Little bit. So you are supposed to transfer this data. From here, I need 1 mm clearance, not from here. What will happen if you do 1 mm from here? You have no business to put your depth reduction on a tooth wear. Imagine I'm increasing the bite now. Already, I've created space. So without this model, you're not supposed to move. Generally, can you fix it because of the glove I cannot. So this is just a sectional model. Full arch model will be there with a mock-up. Yeah. So I will create a putty index. Okay. So I create a putty index. And then before the patient comes, all this is ready. Then I have the temp material. Thank you. The tip was inside this one. So any of the bisacrylates, I put the bisacrylates. So I use this temp, put my temp here, and then run my burr on the temp. Is that clear? So wherever the burr touches, I grind. If the burr does not touch, space is already there. What is the next step? What is the next step? Creating space. Next is path of insertion. Make sure you remove only the undercuts. Then define your margin. Don't forget these 3 steps. First aim is to create space. Next, path of insertion. That means you cannot visually sit on top of the tooth. That's impossible, right? You're working outside the mouth. Scanners do help us a lot in doing this. So I quickly scan and check it up if everything is okay. And then I refine. Otherwise, you can send to the lab and get them see and then do it. And then I define my margins finally. Is that clear? First outline form, then refining your outline form. Okay, let this set. By the time we'll move on to the next side. So you see here, this is a cavity. So here is what you see, a cavity. Yes, this is decay. Somebody asked me, should I do the entire cusp or leave it? It's your clinical decision. So you need to measure with this cusp measurer and then see if this cusp is deemed capable of staying or not staying. If you don't have this instrument, you can use a Williams probe. Okay? If the cusp is less than a millimeter or a millimeter, remove it off. Or if you also see graze lines here, please take that. It's not worth having that. Then you do. This is a typical partially bonded restoration. So what I'll do is that the contact and contour is going to come from the final restoration, not from your bio base. So it's up to you to see if you really need. Is there a wedge available? Sorry, I asked for a wedge. If it's possible, that's okay, no problem. I don't strongly recommend any matrix or something to go. Wedge system. Okay, no, this is also good. Yeah, thank you. So I'll just put a wedge to make sure my gingiva is protected, and then move forward with my bonding. So preferably a plastic wedge goes inside and stays there. Let me see if this is not set. So now I will use my, can you take one of this? So I will use my adhesive here. All the chlorexid and all that stuff stays. The first layer, which I preferably to use flowable. So if your gloves are clean and neat, I generally do this in my practice. So I would put it on a paper pad or on your gloves like this. Take it in your probe and slowly start applying. Okay. A blunt probe preferable. At this stage, if you're putting a polyethylene fiber, you don't polymerize this. Is that clear? Now, I will just polymerize this. I generally use GNL universal flow for this and GNL posterior because I'm going to use Everex here. I'm not using my fiber. So this is Everex. You need to have this. It comes in compules, Everex posterior, fine. So you can see I'm going to inject this, beautifully adapts indeed. Okay, and this is a problem with this because it's really tough. Yeah. Okay. Now you can mold it. Slightly short. Keep in mind that you might reduce this even further. So a very thin layer is also more than enough. Spread it evenly. You see that? On top of that, you're supposed to use a packable composite. Now you build it to full anatomy and then use your burr to see if it's set. So now I'll go back to my regular composite. Try to build the cuspal pattern roughly. Follow the cuspal inclines. Don't worry about the contacts and contours because that's going to come eventually in your fixing. Just see if that is it. No, if it's not sitting, I'll need to get it. Now we'll polymerize it. Send the patient. I generally send the patient off like this. You got the point? The build-up is done like this. I send the patient off like this. And the next time I call the patient and decide if I'm doing a partially bonded restoration or a full cuspal coverage. So if I'm doing partially bonded restoration, just stop half and then do it. Now let me go back to, did it come out? Yeah, come out, super. So forget it, I don't want it. So this is a template, what I'm going to use. So what I do is that I check if this template is fitting well. Yeah. You should have a stop. If you're not having a stop, then it gets difficult. Yeah. Okay. Please check in the mouth before putting it in the patient's mouth, because you need to know where this putty index is laying. I'm just protecting the other tooth because I want to give a demo on bonding. That's a prep tooth. So now can I have the bisacrylate? Now, the gun. Yeah. So just load bisacrylates onto the tooth what you're working on. This is for tooth wear case. Okay. Then just place it here. You know where to place, so accordingly you will put it inside and hold it for some time till it sits hard. Okay. So once it sits hard, then you take it out and then use your depth reduction burr on that. Is that clear? Make sense? So without bringing it to the full anatomy, that is without knowing the final destination, you're not supposed to reduce the tooth structure. Because from there I need 1 mm clearance, not from the starting point at all. So let this set. Then I'll show you. Now going on to pre-endodontics or the endodontic build-up with the deep margin. So deep margin is not subgingival, it is exactly there. Only thing, I'm going to do the elevation here. So the Amazon way. The Amazon way is copper band. It's just 400 rupees, available in Amazon, one full reel. Just have to cut it and use it for deep margin elevation. So I prefer the Toppelmayr matrix band, and I will put band in band. The only thing is that this is very important for interproximal isolation. Teflon tape should be used. I'll just show you how to use it. So I'm going to do this deep margin. Can I have one band? So I teach only this for the participants who come to me, because those are very expensive. You cannot invest so much initially itself, and also you need to charge your patients so much. So this is the best way. Even postgrads, it's very easy. You just have to, all of you can jointly buy one thing. Now you just insert this inside and do not tighten it fully, just have it there. But I would prefer Toppelmayr band also. Okay, because let it be there. Then what you do, cut a small portion of the copper band. Why copper band and not stainless steel is this is very flexible and adaptive, so I will shape it up and then insert it inside. It's like the band within the band, okay? Insert it nicely like this, okay? I'm not talking about contacts, I'm talking about contours. So now I try to adapt this, okay? Clean, can you see that? Now, this is the trick. You need to take the Teflon, take out the Teflon, and then you need to make it like a rope. Fold it into two, make it like a rope. This is the most important step. Make it like a rope, otherwise Teflon, it's very difficult to put it inside. So now insert it like you did your retraction cord or floss. The next step is tighten this. It has to get stable. Okay, tighten this nicely. Then take your plastic instruments and start to slip it inside the gingiva, so that you get good isolation and the clavicular fluid does not interfere with your bonding. If this has to go into the gingiva, guys, don't do this without anesthesia. We don't like to. Otherwise, please give anesthesia. Gingival retraction is the most painful thing. You saw that now? Is it clear, guys? Can you see that? Yes? This is a painful procedure. Now what you do is that adapt this nicely and fold it up so that you get visibility. You saw that, guys, now? Yes? This is Amazon way. Easy way. Now what I'll do, I will actually love to bond. Love to bond this. So Chlorix, then all that stays, guys. Do not be in a hurry to build up the entire cavity sooner. So what I prefer here is a bulk fill composite. A bulk fill flowable. I prefer one from Clinician Choice as a dual pure bulk fill. Try to put little bit onto the seat. So little bit onto the seat, nowhere else. So the same rule applies when you're doing endo also. Only thing, I do all the walls also. Then I would fill it up with Everex and then seal it up. After this, I will inject my flowable. Only not to the contact level. Don't do it to the contact. I don't want the flowable to reach the contact level. That's all. Now I've done the DAB. Quickly, what you do, you take up some composite, regular composite. Just roll it up. Nothing wrong in touching the composite. No textbook tells you that. Quickly roll it up. That reduces the surface tension and create the marginal ridge. This is pre-endodontic build-up for me. Okay? Don't do the internal portion. Even if you're doing a vital teeth, I don't do this actually. Okay? Then you can do your endo work here and then seal up with Everex flow. If you're doing vital tooth, just Everex posterior and seal it up. Is that clear? So the minute you take it out, the gingiva is going to be too much angry, it will start bleeding. So do whatever restorative work what you do. So that is, you seal it up. Can you see? It's not about contacts, it's about contours. Your contours come in your contacts, come in your final restorative work. So when you remove off, you will see, you take an X-ray immediately and see if everything is okay, then you leave it out. Now coming on to this model, I think it's set. So what I'm going to do is take it out and there you are. You see the full anatomy now. Now you will run your depth reduction burr on this. Fine. So let me clear up my interproximal. I think I need another glove. Another glove. Tabletop restorations, I make sure that the occlusal corrections are as minimal as possible, because you cannot check for occlusion before you cement them, they are not stable. So this is, yeah, it's over. Yeah, everything is done. So can I have gloves? Look at this. This is, I got it fabricated from a lab, and this is, sorry. So So this is the tabletop, what I'm going to cement. So let's see the cementing process. So once you've tried the restoration and everything is good, then you need to etch. So can I have a tissue? Yeah, tissues here. So one of the team member will be doing this etching process. So this is the ceramic etching. So I'm going to etch this now. This is the hydrofluoric acid. Okay, you need to etch it for 15 seconds. 15 seconds, and then wash it. Can I have some water? Bowl and water. Little bit of water. Some little water will do. Then you need to ultrasonically clean them, because the red stains will be there. So you need to ultrasonically clean them. Once, imagine you wash them thoroughly. After that, if you do not have an ultrasonic cleaner, right, you're supposed to use phosphoric acid. This will remove all the remnants. That comes with the acid etching. There will be a lot of particles. If you have an ultrasonic cleaner, it's okay. Otherwise, please wash them thoroughly, and then you can apply your adhesive. So once it's clean and neat, then you can apply the, make sure that you apply Rabadam and keep it clean.
उसको अभी प्राइमर वगैरह ला के बॉन्ड करेंगे, लगाएंगे.
So I prefer a W8 clamp here. If 8 is there, no problem. If 7 is there, then I strongly require a wingless clamp. It's easy. Now I'm applying monobond to it. So my restoration is ready. Then I pick up my rubber dam. I'm going to use my, I need a dam, I need a clamp, I need a template. So I do it from canine. When I do 4 teeth, right? I do it from canine, premolar, molar, and I'm going to put a clamp on 8 preferably, or I'll put it on 7 itself. If 8 is missing, then template was outside somewhere. I put it, I need a pen. I think template was here, somewhere here. It's there, that's it. Can I have this clamp? Yeah. So I'm doing it from the canine. So canine, premolar, molar, and I'll do it on 8 itself. So there are 2 reasons why you need rubber dam here. Is because I'm going to air abrade. I don't want air abrasion to happen without rubber dam, and I need perfect isolation. 1 drop of saliva is enough to spoil the entire work what I did. So I'll always love to do with my rubber dam on. Okay. Now this. The more posterior I go, I would love to have this one is okay. Yeah, this one is okay. So I would love to have this. A smaller clamp, either B1 or W8A. If 8 is there, try to utilize 8. There's a bonding in the premolar which I did not, sorry, in the canine which I did not notice. So I'm doing it from premolar to premolar. Clinically, I would love to do it from canine to the molar. That gives me a lot of visibility.
डाउनलोड कर
Floss. So the margins are supragingival, so it's going to be easy for you. It's not going to be really tough. Make sure that the margins are neat, exposed. Only one thing which I want you to do after this, why am I showing this exercise? Is there a reason. After you're done with this, and then you made sure that everything is clean, neat. I want you to do something. What is that something? Why am I doing this is that I want you to put a floss. I don't want any excess on the gingival margin. So again, I think you get it only in Amazon. Super floss. Super floss. I want this inside. Without this, please do not bond your tabletop. So this should be here. Another floss. Yeah. No other floss, guys. It's from Oral-B Super Floss. This has to be like this. Is it clear, guys? This is the reason why I did this exercise, not just to put a rubber up there. Without this, this also absorbs whatever excess adhesive you put or anything. This final clinical tip, what I want to tell is that now you know that my monobond is already here. I'm going to use bottle A, bottle B. There's a resin cement here. Open. Sorry. Bottle A, bottle B. This is a self-cure cement, self-cure bonding agent, self-cure cement. So I will just apply this. I don't have to light cure it. Only one thing which I wanted to give you a practical tip: invisible margin. You know what I'll do? I will put little bit onto the restoration, little bit onto the tooth structure, and pick up a flowable composite, put it in the margin. This will merge your margin completely. You saw my daughter's stuff. So that is because this is a clinical tip. What I want to tell you is that. Got it? Then all you need is this cement. These cements are nice that can have a light cure. You can remove the excess by light curing. So they are strictly self-cure, but the excess can be removed. It takes 3 minutes for the cement to set out. Till then, just do one thing. What one thing? Just move this floss. You saw the resistance it had? The cement will just stick onto that. That's all. Move the floss and just leave it off like that. Is it clear? Wait for 3 minutes and then do. If you're doing multiple teeth, finish up this. This tooth should have a Teflon on it. Why? Any excess cement. Then next tooth. Then next. But my isolation is only this. You got a point. I couldn't put it on. I didn't notice that they had a bonding. Somebody has done bonding here. So I will do one tooth. Teflon. With the Teflon, there will be floss. What floss? Super floss. Then after I remove everything, okay, I have this interdental saw. This after all 4 are done. I need to pass this interdental saw and make sure there is no cement sticking together. Fine. Once I'm done with this interdental saw, I have my finishing strips, metal strips. I insert them and again polish my margins interdentally. Is that clear? Guys, it's not putting some bonding and fixing it there. And then I polish this nicely. Then finally, I run my, can you give me regular floss? Yeah, regular floss is there. Then I run my regular floss only for one reason. Gingiva. One speck of composite in the gingiva, done. Is that clear? After that, then I remove my band, the dam and the plug. Yes, all good. Okay, thank you so much for patiently listening.